Okay. You are live.
Hi, everyone. Good afternoon and welcome to our event, Painful Conditions of the Knee. Our host today is Dr. Paul Steinfield. Dr. Steinfield is a board-certified orthopedic surgeon. He specializes in adult joint reconstruction and hand surgery at Nazareth Orthopedics. And just a couple of housekeeping items before we get started. We are recording this event, so everyone has been placed on mute. And following Dr. Steinfield's presentation, we will have a Q&A session at the end. If you have a question that you'd like to submit, please use the Q&A panel. And when submitting your question, if you could please include your age and also your name if you would like us to potentially follow up with you after the event. We're going to try to get through all the questions during the Q&A session, but if we need to follow up with you offline, it'll be helpful to have your name. And with that, I will turn it over to Dr. Steinfield.
Thank you, Jason. Hi, everybody. My name is Paul Steinfield. As Jason said, I'm an orthopedic surgeon now working at Nazareth Hospital. I've been practicing orthopedic surgery for over 30 years here in Northeast Philadelphia. In 1999, I opened up the Muscle, Bone, and Joint Center, and I treat conditions of the arms and legs. I treat neck and back problems. I treat hip and knee problems and shoulder and hand problems. I take care of kids and adults. I did my hand surgery training at Jefferson here in Philadelphia. Today, I'm going to speak about painful conditions of the knee. I'll tell you how I diagnose and treat these problems and how these conditions get rehabilitated. I'll talk about simple solutions as well as surgical solutions to these painful conditions. So we'll start with the uncomplicated contusion. A contusion is a bruise. A knee contusion occurs when something hits the knee. It occurs when a person walks into a table or walks into a wall or falls on the floor. It is a contusion when there's no fracture or deep laceration. Most knee contusions are bone bruises of the kneecap. Most contusions don't require much treatment, and most contusion pain doesn't last that long. The knee joint is considered a hinge joint. It mostly moves in one plane, flexion and extension. It's made up of 4 bones: the femur, the thigh bone, the tibia, the shin bone, the patella, the kneecap, and the fibula. The fibula sits alongside the tibia. So femur, tibia, patella. Remember, these 3 bones, we'll come back to them over and over again in this discussion: femur, tibia, patella. The white thickened covering over the ends of the bones that you see on the picture is the cartilage. The cartilage is what gives you motion without friction. The cartilage allows your bones to move smoothly and effortlessly. And when cartilage wears away, we call this arthritis. When arthritis develops, the knee becomes painful and stiff. Trying to get some movement here. Sorry. So this is a prehistoric creature, and I've always found it interesting when looking at these skeletons to see how similar our bones are to the bones of dinosaurs. Here, if you look at the red arrow points to the kneecap. The yellow arrow points to the femur, the green arrow points to the tibia, and the blue arrow points to the fibula. This prehistoric creature has a knee very similar to ours. So getting back to contusion, a knee contusion is a bone bruise of the patella. Bone bruises can be as painful as fractures. Patella contusion can turn into a kneecap pain syndrome. Kneecap pain syndromes can drag on forever. Kneecap pain syndromes usually involve the cartilage between the patella and the femur. We call this patellofemoral pain syndrome. So patellofemoral pain syndrome is characterized by pain right over the kneecap. People complain of clicking, they complain of crunching. They often talk about a Rice Krispie sensation, the snap, crackle, and pop sensation within their knee. Patients complain of pain going up and down steps. And the treatment for this condition is physical therapy. Physical therapy is exercise therapy. It's really all about getting the muscles around the knee stronger, getting the muscles conditioned and balanced. I usually recommend 4 to 8 weeks of physical therapy for this type of condition and for most conditions. The physical therapist uses things like elastic bands, free ankle weights, and knee press machines. The treatment of patellofemoral pain involves some very easy and simple exercises. This is not one of them. The exercise should be done every other day, and after 4 to 8 weeks of physical therapy, a home exercise program is usually recommended. Other treatments that can be helpful for these kneecap pain syndromes include things like bracing, taping, and acupuncture. Surgery is occasionally indicated when simple measures fail. So this is an X-ray that demonstrates a method of surgical treatment for painful kneecap condition. The tibia, the shin bone, is just below the femur and patella, which you really don't see much of on this picture. The tibia has been cut with a bone saw. This cut segment of bone is the attachment site for the tendon that pulls on the kneecap. So the star that you see is lying over the bone segment that's been cut. And by cutting the bone here and shifting the bone segment, the contact force between the patella and the femur is changed. So this bone segment is shifted in the direction of the blue arrow, and this shift changes the way the tendon pulls on the kneecap. And by doing this, the stresses on the kneecap are shifted and pain often settles down. 2 screws are used to maintain this new position of the bone segment, and recovery from this procedure is about 12 weeks. Now, this is a very painful injury that is not so uncommon. This is a broken kneecap. Fractures in general are terribly painful. Bones have nerves, bones have blood vessels, and broken bones bleed. This injury usually occurs from falling. The 2 bone segments of the patella are widely separated, as you can see, and this requires surgery. There really is no way that these 2 bone fragments are going to heal. This is just one type of many bone fractures. And this is how we fix this type of fracture. The 2 pieces of the patella, the 2 pieces of the kneecap are put back together and held temporarily with a bone clamp, and then we place 2 screws. These screws are cannulated, which means they're hollowed out. And so with these screws, we can reinforce the strength of the repair with a wire that's passed through the screws in a figure of 8 fashion. The wire is then twisted and tightened, and that adds to the compression force on the fracture site and helps stabilize the injury. These fractures take about 8 weeks to heal, but they can still be painful for up to 2 or 3 or 4 months afterwards. Tendon ruptures occur most often in athletes under the age of 40. These are injuries that are most frequently seen in football and basketball. The patellar tendon is a big, strong tendon that connects the kneecap to the tibia. These injuries occur as a consequence of the quadriceps muscle, the big thigh muscle, contracting as the knee is forcefully bent, just like what happens in a tackling injury. The tendon gets pulled off the bone. This was a season-ending injury for the running back Cadillac Williams, who played with the Buccaneers. He had the surgery, and after he came back the following season in 2008, he ruptured his other patellar tendon that required surgery, and he came back the next year, but his career kind of fizzled out after that. This is what a patellar tendon rupture looks like on an MRI study. This is a side view of the knee. The arrow points to the void where the tendon has torn. The T's that you see are over the 2 ends of the tendon, and this is where sutures will be placed to repair the tendon. Usually the tendon tears off the kneecap, and to fix this injury, sutures are placed through the torn tendon and then pass through these drill holes that you see in the patella. The sutures are then tied on top of the patella where you see the red arrow. Patients are then braced for 10 to 12 weeks. The brace keeps the knee from bending and allows the tendon to heal without stress on the repair site. Talk about painful conditions of the knee. We'll skip this one. In older people, the quadriceps tendon is more of a problem. Again, in younger people, it's more the tendon of the patellar tendon. And in older people, the quadriceps tendon is the tendon that can rupture. The quadriceps tendon attaches to the big thigh muscle called the quadriceps and attaches the quadriceps to the kneecap. And these injuries are also a consequence of a fall. And what happens is that the quadriceps tendon tears away from the patella, just like the patellar tendon tears away from the patella. And when this happens, the person is unable to extend their knee. That means that when they're lying down, they can't lift up their leg. Same thing happens when a patella fractures. So with these injuries, it's impossible to put any weight on the leg. The knee will buckle. The picture on the right is an MRI. The red arrow shows the gap between the patella and the quadriceps. This image shows what a complete rupture looks like at the time of surgery. So the left end of the incision is the patella, that's the kneecap. And just to the right of that, you can see the tear where the muscle is completely torn off the patella. And again, this is repaired in a similar manner to the way the patellar tendon is repaired, with sutures running through the tendon. The sutures are then attached to the patella through drill holes in the bone. And similarly, after this surgery is done, a patient will wear a brace for 10 to 12 weeks to protect the repair, and will need usually 8 to 12 weeks of therapy. So again, these injuries are much more common in people over the age of 40. The x-ray on the left shows a fracture of the tibia. This x-ray shows a high energy injury. This type of knee injury occurs as a consequence of a car striking a knee. The x-ray on the right shows what a normal x-ray of the knee looks like. So the x-ray on the left shows a fracture which is displaced. The red arrow points to a depression in the bone, which needs to be fixed. If the fracture is not repaired surgically, the knee will quickly run into problems with deformity and stiffness, instability, and eventually arthritis. And this is how these types of fractures are repaired. We use plates and screws. Bone is hard, it's strong, it holds screws very well. In fact, ounce for ounce, bone is stronger than steel. Bone is considered 4 times stronger than concrete. After surgery, patients are protected in a hinged knee brace. This brace allows the knee to flex and extend. Physical therapy usually starts immediately after we fix these fractures. And physical therapy really focuses on restoring motion and strength. Patients have to use crutches or a walker so that they don't put all their weight on the leg for 8 to 12 weeks. The meniscus is something everybody hears about. You hear a lot about the meniscus. The meniscus is the shock absorber of the knee. It protects the cartilage of the knee, and it's only found in the knee. When it's injured, it tears, and when it tears, it causes pain. The meniscus has a poor blood supply, so it doesn't heal well after it's torn. Here you see the femur, you see the patella and the tibia, and the meniscus sits between the tibia and the femur. There are 2 menisci in each knee. This is a picture of the back of the knee. The meniscus sits between the cartilage of the femur and tibia, so the blue stars show where the cartilage is, above the meniscus on the femur and below the meniscus on the tibia. Cartilage is found wherever a joint exists, and it covers the ends of bones. So the meniscus has consistency of rubber. It tears either as a consequence of a twisting injury or as a consequence of aging. The meniscus loses its strength as we age. There are many people out there who have meniscal tears and have no pain. It's important to understand that not all tears are painful, and likewise, not all arthritis is painful. A painful tear of the meniscus can quiet down on its own, and the pain can go away without treatment. That's possible, but more frequently the pain doesn't go away. Likewise, a tear that's not painful can eventually become painful. Activities like stooping or squatting can turn a small tear into a large tear. In younger people, tears occur more from high energy injuries. So in a younger person, it takes much more energy to produce a meniscal tear. And that's because the meniscus is healthier, it's stronger, and it's more resistant to energy. These tears behave differently than the tears seen in older people. Tears in younger people are usually treated differently than tears in older people. Tears in younger people have more of a potential to heal. Patients with tears of the meniscus complain of pain, they complain of swelling and stiffness. Sometimes they'll complain of locking and they'll say that their knee gets stuck. They'll have increased pain with twisting, pivoting, and increased pain with side-to-side motions. Rest often does help relieve their pain. People who have meniscal tears complain of pain getting out of a car, pain getting out of a chair, pain getting out of bed. Many people will limp and will need the assistance of crutches or a walker or a cane. This is an MRI of a torn meniscus. So the meniscus appears as a black triangular structure. Within that circle, that yellow circle, you see that sideways triangle. And when it's torn, there will be a gray signal inside the black triangle. That gray signal is fluid. The fluid inside the tear, the fluid is inside the tear of the meniscus. And when you're looking at this picture here, you're looking at a side view of the knee, and the red arrow from the MRI to the anatomic drawing shows you the relationship of the drawing to the MRI where the meniscus sits. Initially, like most injuries, rest and elevation is helpful. Rest and elevation always helps, at least for the first few days. Then anti-inflammatory medications can be helpful. Ice is often very helpful early on. And even if there's a tear, physical therapy can be very helpful for meniscal tears. So in the early stages of therapy, when a therapist is treating a torn meniscus and there's a lot of pain, the therapist will limit exercises based upon the patient's expression of pain. Often with meniscal tears, arthroscopy is used to treat the tear. And with arthroscopy, a small lens is placed inside the joint, and then small instruments are placed inside the knee to treat the problem. The surgeon watches the screen to do the surgery. Arthroscopy has been around for over 50 years. In most cases of a torn meniscus, the torn segment is removed, leaving the healthy segment behind. In most cases, 50% or less of the meniscus is removed, and the 50% of the meniscus that's left behind still functions as a meniscus. So this is an arthroscopic image of a torn meniscus. This is a picture taken inside the knee. The arthroscopic lens is inside the joint. The frayed tissue is the torn meniscus. The probe is used to feel the tear and to better determine the extent of the tear. The goal of surgery, again, is to remove the torn segment, leaving the healthy segment of the meniscus behind. The removal of the torn segment is done with little biters and motorized oscillating shaving devices. Same thing here, the meniscus is torn. Instruments are placed inside the joint to remove the torn tissue. The surgeon will continue removing torn tissue until healthy tissue is seen. These procedures typically take 30 minutes. 2 or 3 puncture holes are made through which these instruments are placed. This is a before and after picture. So you see the tear on the left, and on the right, that segment has been removed, giving you a remnant, which again still functions as a meniscus. The procedure is called meniscectomy, which is removal of meniscus. Some meniscal tears are repairable. Younger people get tears that, again, are different from tears in older people. And in younger patients, the meniscus is healthier and stronger, as I said. In younger patients, the tears occur closer to the periphery, the outer edge. Here at the outer edge, the periphery, is where there is a blood supply for the meniscus. The inner edges of the meniscus are bloodless, and without blood, the inner edge tears will not heal. The outer edge tears can be repaired arthroscopically with what are called suture anchors. And this is a picture of a device that's placed through the skin and into the joint, and the meniscus is then repaired with a retractable needle. The retractable needle allows for the placement of 2 of these suture anchors, which are part of the same implant. So the needle is passed through the meniscus twice, and each time it's passed, a suture anchor gets implanted. The 2 suture anchors and the suture in between form a very stable construct for that torn meniscus, and as the device is pulled out of the knee, the end of the suture comes out with it. The surgeon pulls on that suture and tightens the repair. So this is a pretty slick design that's probably been modified countless times over the past 30 years. Every year or two, the instrument makers come out with better designs for a more simple procedure for everyone. Recovery from meniscal surgery varies from person to person. Some patients bounce back quickly in 2 to 4 weeks and are able to get back to running and athletic activities. Some require 2 or 3 months to get better. After a torn meniscus is excised, as I've shown you, or after it's removed, there's really no need for crutches or a walker. But after a meniscus has been repaired, the patient needs to be on crutches for 6 weeks to allow for healing. 6 weeks on crutches leads to knee weakness, which is why physical therapy is needed, especially with these meniscal repairs, to help restore strength and regain normal function of the knee. What about older people? As I said, some meniscal tears require surgery, some meniscal tears do not. In general, in people over the age of 65, we try to avoid meniscal surgery. Studies have shown that in people over the age of 65, there's no long-term benefit to removing part of the meniscus. In people over the age of 65, surgical and non-surgical methods seem to work equally well. In the over 65 age group, the torn meniscus is considered part of the arthritic process. Cortisone works very well in older people with meniscal tears. An injection of cortisone reduces inflammation and pain usually settles down. After a cortisone injection, the tear doesn't go away, but the inflammation settles down. And usually the pain goes away, sometimes permanently and sometimes not. In many people, meniscal tears are the beginning of a progressive course of arthritis. When the meniscus tears, some of its shock absorbing function is lost. Remember, the meniscus protects the cartilage, so once the meniscus is injured, it loses some of its ability to protect the cartilage. So when the meniscus tears, degeneration and wearing and tearing of the cartilage speeds up. So meniscal tears, again, are often the beginning of arthritis. Just a word about cortisone. Cortisone is man's best friend. Cortisone's a miracle drug. It's our silver bullet. It works very well in painful joints all over the body. It works by reducing inflammation. Inflammation is the primary source of pain in most joint problems. Cortisone is a steroid. Steroids reduce inflammation. Inflammation is the culprit. Getting rid of inflammation is the key to happiness. Moving on to ligament tears. Ligament injuries of the knee are, again, more common in sports. As we get older and our bones become less strong, injuries that in younger people would cause ligament tears produce fractures instead. Ligament tears are usually caused by a forceful, high-energy injury, and there's usually a significant rotational component to the injury that goes into producing the ligament tear. This is the most well-known professional sports injury. Here, the mechanism of injury is a rapid change in direction or a sudden stop or landing from a jump or direct contact to the knee. This is the anterior cruciate ligament tear. The tear produces instability of the knee, and the instability produces buckling and giving way. The instability allows for excessive motion between the tibia and the femur. The anterior cruciate ligament is also referred to as the ACL. ACL injuries are the curse of the NFL. Most athletes can get back a year later after they've had the surgery. I'm sure everybody remembers Darren Sproles, Jeremy Maclin, Donovan McNabb, and of course, Carson Wentz. These players all had ACL tears, they all had ACL surgery, and they all went back to playing. The Lockman Test is something you'll see trainers at football games doing all the time. You'll see a trainer or a doctor run out onto the field after an injury has occurred, and the doctor or the trainer can do this examination maneuver called the Lockman Test to determine very quickly if there is an ACL tear. The late Dr. John Lockman was chief of orthopedic surgery at Temple University Hospital. He invented this very simple test. It's now used the world over to quickly make the diagnosis of ACL tear. And to do this procedure, the tibia is grabbed with one hand, the femur is grabbed with the other hand, and an attempt is made to draw the tibia forward. If the tibia can pull just a little bit forward, the test is positive and the ligament's torn. MRIs are always used to confirm the diagnosis of an ACL tear, and they're also used to look for other injuries such as a meniscal tear. The image on the left is the image of a normal knee with the ACL appearing as that black oblique line. The image on the right shows the absence of that black oblique line, and this is an ACL tear, when you don't see the black line. For most people under the age of 40, ACL tears are treated surgically. For people over 40, there are a number of factors that need to be considered in deciding whether or not these people should have surgery. So in people over 40, the things I think about is the person active? Is there also a fair amount of arthritis of the knee? Does the patient have a stable knee? Does the patient complain of buckling and giving way? And is the patient able to, and is the patient willing to undergo a fair amount of post-operative physical therapy? These questions help me and help everybody make a decision in people over 40 as to whether or not they should have this surgery. Now, when surgery is indicated, when ACL surgery is indicated, ligament, it's not repaired, it's rebuilt. And it's not repaired because repaired ACLs don't do well because of the blood supply getting ruined or getting injured during the ligament tear. So when ACLs are simply repaired with sutures, it's a weak repair and they tend to fail. And so over the past 4 decades, we've come to reconstructing the ligament. So the ligament, it's rebuilt either using cadaver tissue or using the patient's own tissue. When the ligament is rebuilt using cadaver tissue, this is called allograft reconstruction. And when the ligament is rebuilt using the patient's own tissue, we call this autograft. And this is a different type of autograft. That's not what we're talking about. But the graft that's used is soft tissue that reconstructs the ligament. The graft is taken either from the patient or from a cadaver, as I said, and sutures are passed through the end of the graft. And the graft is then passed through large drill holes or bone tunnels. And by doing this, the path and the function of the ligament is recreated. The graft is then secured to the bone holes with screws, sometimes with buttons. This is all done arthroscopically, and this is done to restore the stability of the knee. So when this ligament is torn, again, it's not repaired, it's reconstructed, it's rebuilt. A word about allograft. Allografts are taken from cadavers. Autografts are taken from movie stars. Now, autografts are taken from the patient. We use cadaver parts all the time in orthopedics. It is a bit gruesome. Studies have shown that allografts are not quite as strong as the patient's own tissue. The advantages of using allograft include decreased surgical time, less post-operative pain, and one less incision. There have been lots of advancements over the years in screening and sterilization processes, and it's really reduced and removed the possibility of disease transmission from cadaver to patient. These allografts are prepared so they contain very little protein, and with very little protein, there's a very tiny risk of graft rejection. We really never see graft rejection. So again, there has been some debate about ACL reconstruction in people over 40. In the 1980s, people over 40 just did not get the surgery, but that has changed. In general, in people who have significant arthritis, we don't do ACL reconstructions. In people over 40, it's reasonable to try non-surgical treatment. Non-surgical treatment includes bracing and physical therapy. Not all ACL tears are unstable and have to be fixed. Some people with ACL tears do not have unstable knees. Their knees do not buckle and give way. And these people can do very well without surgery. If a person over 40 has a demanding job, or if a person over 40 wants to remain physically active, surgery makes sense. In people over 40 who have an ACL tear and are not involved in physical work and don't have a particularly active lifestyle and don't complain of buckling or giving way, ACL surgery can be avoided. Again, in older people who are limited in their activity because of their unstable knee, surgery is indicated. So ACL surgery does not have to be done at the time of the injury. It can be done months later, and probably about 50% of all the ACL tears seen in our country undergo surgical repair or reconstruction. After ACL surgery is done, the patient's put through a vigorous course of physical therapy. Therapy starts within 2 weeks. First, motion is restored, and then strength is focused upon. Return to function can take up to 6 to 9 months. Physical therapy after an ACL repair may be needed for 6 to 8 months, depending upon the needs of the individual. Some people can get by with 3 to 4 months. Some people need up to 11 to 12 months if they're going back to professional sports. Let's talk about cartilage injuries. Cartilage injuries occur in younger people and are often associated with sports. Remember the difference again between cartilage and meniscus. The meniscus is the shock absorber of the knee. The meniscus, again, is not found in any other joint. It protects the cartilage. Cartilage covers the ends of bones at the joints. Cartilage has a frictional coefficient, about 1/5 of ice on ice. And that means that cartilage is 5 times more slippery than ice sliding on ice. When cartilage is injured, a defect appears on the surface of the bone. When the bone is injured, like most other structures in the body, the bone can regenerate and heal. When cartilage is injured, it cannot regenerate. Cartilage injuries can lead to early joint degeneration. Articular cartilage has no blood supply, and consequently, there really is no opportunity for new cartilage to form after cartilage has been injured. Usually when cartilage is injured, it comes off the bone, it peels off the bone. Sometimes it can be put back, sometimes it can't. Activity after cartilage is damaged, especially in sports, can lead to more cartilage damage and can lead to early arthritis. When a cartilage injury occurs, the joint swells up with blood. The blood comes from the bone. After the initial pain settles down from the injury, there will be activity-related pain. People often complain of catching and locking. And again, MRI is the best tool for making the diagnosis of a cartilage injury. This MRI shows the common occurrence of a cartilage injury occurring at the same time as a bone injury. With time, the bone will heal, but the cartilage, which has peeled off the bone, really cannot heal. So when we put an arthroscope into people's knees with cartilage injuries, we can see a shearing away of the cartilage. And I try to put these back, these cartilage chunks back where they belong, as does anybody else who sees this type of cartilage injury. And sometimes I will use tiny absorbable pins that hold the cartilage in place, and over time the pins disintegrate. Sometimes I'll try to generate new cartilage to fill the gap by drilling tiny holes into the bone. And what this does when you drill these tiny holes in the bone is that it allows bone marrow to seep into the joint. And these little droplets of bone marrow contain stem cells, and the stem cells will generate new cartilage and new cartilage cells. So this is a technique that we use to make tiny drill holes in the bone. Sometimes we use a drill, sometimes we use an awl like you see here. It's an arthroscopic technique, so just some puncture holes around the bone, around the knee rather. And we either use, like I said, the sharp awl or drill bits to make tiny holes in the bone. The bone holes are penetrated down to the bone marrow. The bone marrow then seeps into the joint. The bone marrow cell is a type of stem cell, as I said, and this type of stem cell can differentiate into cartilage cells. When we talk about differentiation, it means it can turn into a different type of cell. So the bone marrow cells turn into cartilage cells and can then multiply. This procedure is called chondroplasty. Another approach to cartilage injury is to replace the cartilage rather than repairing it. So I showed you two methods of repairing the cartilage, one by placing pins, the other by generating new cartilage by making holes in the bone. This picture demonstrates a technique where cartilage is transplanted from one part of the bone to another. So what we do is we take these small cylinders of bone and cartilage using these devices that harvest these cylinders. And these areas are taken from the edges of the bone. These are called the donor sites, and they're packed into the cartilage defect, as you see on the bottom left of this bone. So the plugs are made of bone and cartilage. They're taken from an area of the knee where there are low stresses. The plugs are transferred to the site of the cartilage injury where there are significant stresses on the bone. The donor site is where the femur meets the patella, and where the femur meets the patella, there really is much less stress on the cartilage compared to the defect region. The defect site is where the femur rubs against the tibia, and here there is much more pressure applied to the cartilage. So basically, we're transplanting cartilage from an area that will do okay without it to an area where it's really needed, from an area of low stress to an area of high stress. This is a magnified picture of a typical bone and cartilage plug that's been harvested with a little carving device. On average, the cartilage defect usually measures between 2 and 3 centimeters, which is less than 1 inch. It's important that when these cartilage plugs are placed, that they're placed in the fashion where they're flush with the rest of the cartilage, so that the surface when we're done is totally smooth. And then patients use crutches for 6 weeks to allow this to heal. So there is one more way to treat a cartilage injury, and this is a two-stage procedure. In the first stage, the arthroscope is placed inside the knee, and where you see the donor site, small pieces of cartilage are taken from the donor site using little grasping devices. This is a 30-minute procedure. The doctor then takes those little pieces of cartilage and sends them off to a lab. The patient goes home. The cartilage cells stay in the lab for several weeks, where the cartilage cells are placed in a special broth, and the cells multiply in that broth. And then when enough cartilage cells are grown to fill that measured defect, the cells are sent back to the surgeon, and the patient is brought back to the operating room, and then 2 incisions are made. In one incision, a small patch of tissue is removed from the surface of the tibia, and this is called the periosteum. And the piece of periosteum, that's the P in the picture, that piece of periosteum is a patch that's sutured over the cartilage defect. So this next picture shows that this defect has been covered by a patch of periosteum, that's the P, and the periosteum has been sutured to the edges of the defect. And now what's done is that the cartilage cells are in the syringe and they're injected into the defect, where they will grow, multiply, and solidify, and 6 weeks later, you have brand new cartilage. The consequence of these cartilage injuries has been studied the most in athletes, and a number of studies have shown very significant incidence of arthritis that occurs usually 10 to 15 years after these injuries if they're not repaired. And this, of course, is especially true with high-demand athletes. So when cartilage injuries are not repaired, permanent cartilage damage results. And as we get older, cartilage wears away, and we call this cartilage loss. Cartilage loss is also called arthritis. Arthritis occurs in all of our joints. Arthritis occurs in all mammals, and dinosaurs have been shown to have arthritis as well. Arthritis can be mild, arthritis can be moderate or severe. Now, as I said, mild arthritis sometimes can produce severe pain, and severe arthritis sometimes can produce mild pain. So here's what arthritis looks like on an X-ray. The image on the left is the normal knee. The image on the right is an arthritic knee, where instead of there being a space between the bones, we have bone on bone and loss of joint space. Looking at the picture on the left, the joint space between the 2 bones is not air, it's cartilage. The space between the 2 bones is made up of the cartilage from the femur and the cartilage from the tibia. And because cartilage does not show up on X-ray, it looks like a space of air. So arthritis develops when cartilage wears away, which is part of the natural aging process. So what causes arthritis? I've already talked about the first 2 causes. Wear and tear is the most common cause, and wear and tear is influenced by genetics. Some people are predisposed to having severe arthritis because it's in their DNA, just like some people are more predisposed to having cancer. It's associated with their family history. Wear and tear is accelerated by weight. Obesity is a problem that affects so many aspects of health. The more weight you carry, the more likely you are to develop arthritis sooner than later. Inflammatory diseases like rheumatoid arthritis can produce severe cartilage damage. In rheumatoid arthritis, the body's immune system attacks the joint. Fractures, another cause, can cause cartilage damage. Fractures around the joint can speed up the wearing and tearing process by changing the contact force of the bones and the cartilage. Most cases of arthritis are associated with inflammation. Inflammation is the cause of most of the pain that we see. Inflammation, it's associated with pain, swelling, warmth. Things like redness and stiffness and loss of motion are associated with inflammation. When something becomes inflamed, pain follows. Inflammation can come and go. As I said, many people have arthritis, and severe arthritis can cause no pain, and that's because there's no inflammation. If there's no inflammation, again, there's no pain. Many people have mild arthritis and have severe pain because they have inflammation. So inflammation can come and go for all kinds of reasons, the most common being an injury. Injuries always lead to inflammation. Sometimes the cause of inflammation isn't clear, but inflammation is the cause of pain. You can have gout and have no pain, but when the gout flares up, when inflammation sets in, then pain begins. Eliminating inflammation is very often the key to treatment. Arthritis pain is all about inflammation, And once the inflammation settles down, arthritis pain stops. So the goal in treating arthritis is to reduce or eliminate the inflammation. Once the inflammation is gone, the pain's gone. The arthritis is still there, but the pain's gone because the inflammation has been effectively treated, and we have lots of ways to treat inflammation and arthritis. So these are the basics of arthritis treatment. Rest and ice is advised for early on stages of the onset of inflammation, and anti-inflammatory medications are always very helpful at doing what they're meant to do, which is reducing inflammation. These are the arthritis medications. There are many medications that treat arthritis, many that we no longer use, many we're still using, and new ones coming out all the time. These arthritis medications, most of them are anti-inflammatory. Most of them are used to reduce inflammation. Most of these are over the counter. You don't require a prescription. The anti-inflammatory medications include all of the listed medications here except for acetaminophen. Virtually all of these drugs, and all drugs in general, have side effects, which you probably know by watching the commercials during the evening news. Anti-inflammatory medications have a risk of intestinal bleeding and kidney injury. Patients who have cardiovascular disease have a higher risk of problems with these anti-inflammatory medications. There is a risk of increased blood pressure, heart failure, and stroke in these patients when taking anti-inflammatory medications. So of all these medications, the safest medication to take, without a doubt, is acetaminophen, better known as Tylenol. Unless you have liver disease, you can take up to 4,000 milligrams of Tylenol a day, and that's 8 extra strength Tylenol a day. I usually recommend 2 every 8 hours. I tell my patients who have arthritis that it's best when using these anti-inflammatory medications to take these medications as needed, and not twice or 3 times a day, and not every day. I tell my patients who have a cardiologist to check with the cardiologist first, because some of the cardiologists really believe that these anti-inflammatories should never be used in people with heart disease. Physical therapy helps with any painful condition of the musculoskeletal system. Through exercise and strengthening and aerobic training and conditioning, arthritis pain gets better. Often I'll recommend 4 to 8 weeks of therapy, and then I'll get my patients involved in a home exercise program. Physical therapy is the best treatment because it's holistic, it's natural, it's health focused. It doesn't rely on medications, it doesn't rely on injections or surgery. Weight loss can reduce the pain that's caused by arthritis. Losing weight can significantly slow down the arthritic process. And likewise, activity modification can help reduce the pain caused by arthritis. So going from playing basketball to playing golf can make a difference. Going from construction worker to construction supervisor can make a difference, although that can be very difficult. Going from running to biking can make a big difference in terms of reducing the pain and progress of arthritis. Glucosamine and chondroitin sulfate are considered dietary supplements. Glucosamine and chondroitin sulfate are actually found within our bodies. These substances come in pill form and can reduce the pain of arthritis. There are very few reported side effects when using this dietary supplement. The problem is this is not FDA regulated, and so recent investigations have shown that what they say that's in the bottle is not always in the bottle. That's often the problem. So getting back to cortisone, cortisone is a steroid, and it's used to reduce inflammation. Cortisone can be injected into the knee to reduce inflammation and reduce pain. Cortisone often provides short-term pain relief, but cortisone can produce problems. Overuse of cortisone can accelerate cartilage damage and cause cartilage breakdown. Overuse of cortisone has been shown to speed up the arthritic process, and repeated use of cortisone is really not recommended. About 70 years ago, scientists realized that rooster combs contain hyaluronic acid. Hyaluronic acid is another substance that is found in our bodies. It has a very gooey and slimy and slippery consistency. A rooster comb is the red skin at the top of a male chicken's head. Patients often come into my office and say, "Can I have one of those chicken fat injections?" Well, chicken fat is what my grandmother used to spread on a piece of toast. The rooster combs in a male rooster contain the hyaluronic acid and not the chickens. And this hyaluronic acid does have medicinal properties. So hyaluronic acid was discovered in 1934 by this fellow, Carl Mayer, in an ophthalmology lab, an eye lab at Columbia University in New York. He found the substance in the eyeballs of cows. The substance was very viscous and gooey and slimy, so we figured that it might have some therapeutic use. But taking the goo out of cows' eyeballs didn't seem like a great way to produce the substance. And then came along Dr. Balzak, a Hungarian scientist who also trained and worked at Columbia. And using Mayer's ideas, Balzak figured out that in the early 40s, you can find and use hyaluronic acid from rooster combs. But I will say that grinding up rooster combs doesn't seem to be a great way to mass produce hyaluronic acid either. But that is one of the techniques for producing it. Hyaluronic acid is a complex carbohydrate. It's a component of joint fluid and a component of cartilage. Hyaluronic acid is found in skin, it's found in nerves, and it's also found in certain bacteria. And that bacteria allows for it to be grown in the lab. So hyaluronic acid can be grown in the lab from bacteria. And that's a good thing for all of you roosters out there. So since the 1970s, or I should say since the 1970s, hyaluronic acid has been injected into the arthritic knees of racehorses. The compound was used in human beings in the early 80s. The drug company Pfizer figured out how to breed roosters to have these giant rooster combs. At one point, the combs grew so large that the roosters couldn't keep their heads up. But when injected into the knee, hyaluronic acid increases the viscosity of the joint fluid. It's been found to also have some anti-inflammatory effects. The injections provide what's called viscosupplementation. The injections improve or supplement the joint fluid viscosity, viscosupplementation. Every joint in the body has joint fluid. The joint fluid has a consistency of egg white. Joint fluid provides nutrition to the cartilage and lubricates the joint. In arthritic knees, the joint loses its lubricating properties. The joint fluid loses its lubricating properties. These viscosupplementation injections improve the viscosity of joint fluid. You can think of it as oiling a machine. These injections last for about 6 months, so it's reasonable to do them twice a year. Aside from allergic reactions and a brief flare-up of pain, no significant side effects have been found by using this hyaluronic acid. Patients with severe knee arthritis eventually stop responding to hyaluronic injections. Patients with severe knee arthritis eventually stop responding to standard treatment regimens, and that's because there's nothing to work with. The cartilage is gone, and what's left is bone, and bone is on bone here. The image on the right shows a normal knee. The space between the bones, again, it's not air, it's where the cartilage is. The x-rays on the left show severe arthritis with bone on bone. There's no cartilage left. When arthritis is this severe, it can be very difficult to control the pain without surgery. When x-rays show complete collapse of the joint space and the injections and the medication and the physical therapy don't help, surgery is the solution. One of the most successful of all surgical procedures is the knee replacement. I've been doing knee replacement surgery for 30 years, and it is the solution to a painful arthritic knee when all else fails. In this procedure, the worn out surfaces of the knee are replaced with metal and plastic components. The arthritis basically is removed from the knee. These components are cemented. We use bone cement to keep them in place. We take every precaution to keep everything sterile and free of bacteria during the procedure. We wear these special suits which help maintain sterility. We give patients antibiotics before, during, and after the surgery to prevent infection. Surgery is usually done with a spinal anesthetic. It's safer for the patient. Patients are seen by the physical therapist the same day of the surgery and start walking the same day after the surgery is done. Patients are prescribed aspirin usually for 4 to 6 weeks after the surgery, and this helps prevent blood clots. Many people have minimal pain after surgery. Some people have severe pain that lasts for the first 2 weeks. Recovery from the surgery is between 2 and 4 months. Return to work is between 2 and 6 months, depending on how physical the work is. Most people use a walker for the first 3 weeks, then use a cane for the next 3 weeks, and by the 7th week, they're walking independently, and that can be sped up in younger people. Recovery from knee replacement in general is slower than recovery from hip replacement surgery. So at Nazareth Hospital here in Northeast Philadelphia, we had just introduced robotic surgery. What this does, it allows the surgeon to be super precise in making the appropriate bone cuts. It allows us to be very precise with our measurements, and this provides for a more perfect placement and alignment of the knee replacement. It really makes us better surgeons by allowing us to be more precise. The more precise we are, better the patient will do, and the longer the prosthesis will last. The first knee replacement was done in 1968. Now over 1 million knees are replaced every year in this country. It's probably one of the most frequently done costly procedures in the US. Some leading medical economists think that too many knee replacements are being done too soon. Critics say that many patients who have the knee surgery haven't tried enough non-surgical treatment. I tell my patients that knee replacement is usually the last treatment option. We always try simple things first, which usually are very effective. And when pain persists and non-surgical treatment is no longer effective, surgery is the solution. With new technologies coming out every year, we expect knee replacements to last 20 to 25 years and maybe longer. Knee replacement surgery and hip replacement surgery dramatically change people's lives. Activity is increased, function is improved, and people are able to do more. Patient satisfaction has been shown everywhere to be very high. Pain-free activity allows people to stay healthier and more physically fit. And pain-free activity, I believe, probably contributes to people living longer. So that wraps up my discussion. And I think we may have some questions from the crowd. I'm happy to take your questions.
Thank you so much, Dr. Steinfield. We do have a few questions that came in. Let's jump right into them. The first one comes from somebody indicating they are 74 years old. I had a knee replacement 1 year ago, and I am still having pain. I saw my surgeon at Rothman 2 months ago, and he said I should give it more time. That was the question.
Well, the pain really should be gone by a year after the procedure. Some people bounce back quickly from the surgery. Some people take 3, 4, 5, 6 months to get better. If you're still having pain at 1 year, there's a problem. There are a number of reasons why a knee prosthesis is painful at 1 year. There's often issues associated with the placement of the prosthesis, the way the surfaces articulate together. There's always a low possibility of infection. There's always a possibility that something else may be contributing to the pain. And if at a year's time you're still having pain with your knee replacement, it really does make sense to get a second opinion. It really does often take a second set of eyes to understand that there's something else going on, or there may be something else going on which needs to be investigated and treated.
Thank you. Another question. I'm 52 years old. I went to the emergency room last week for knee pain, and I was told I had a Baker's cyst and it had to be drained. Do you drain Baker's cysts?
So Baker's cysts are a common finding in many people. Usually they occur as we get older. Baker's cyst is a cyst that occurs behind the knee. It can produce a fullness in the back of the knee. In general, it is not the source of pain. It's a consequence of something else going on inside the knee. So we'll often see Baker's cyst associated with meniscal tears. We'll often see Baker's cyst associated with arthritis. Basically, the joint fluid gets pushed out of the back of the knee into a little cavity which forms a cyst. So these cysts can be drained. Sometimes they're injected with cortisone, but the key is to first figure out what is causing the cyst. Is it a torn meniscus? Is it arthritis? If it is something definitive and that definitive issue is treated, often the Baker's cyst will settle down, the fluid will diminish, and the symptoms, again, are not really coming from the Baker's cyst, it's coming from the other problems. So Baker's cysts can be drained. They're usually not drained because the issue first needs to be understood in terms of what's causing the problem. Once that problem is taken care of, the Baker's cyst tends to not be an issue anymore. But understand, in closing, that the Baker's cyst is not the source of your knee pain.
Thank you. And this one just came in. Do obese patients have to lose weight prior to knee replacement?
It's been shown that people who are over a certain weight, we look at a BMI, which is a calculation of weight versus height. If people have a high BMI, if they're overweight, we have found, and studies have found, that there are increased complication rates from surgery. So across the board, people who are overweight and considered obese have a higher chance of having complications, namely infection. And knee infection after a joint replacement is a total disaster, and any surgeon will do anything to avoid that potential complication, including asking an overweight person to lose weight. So it's very difficult for heavy people to lose weight to the point where they're not obese anymore. But some loss of weight is better than no loss of weight, and most surgeons who do joint replacement surgery will ask their heavy patients to lose weight to try to get below the BMI of 40, which is that magic number that we look at. Again, it's a ratio of weight and height. And if they can't get down to 40, but they at least come down significantly in their weight, it makes it an easier procedure and a less complicated procedure, and a procedure that has a better chance of having no complications.
Thank you. A few more questions here. This one from someone 63 years old. I had 2 cortisone injections over the past 3 months and they did not work. What do you suggest?
Well, the question is, what's causing your knee pain? At the age of 63, arthritis is common. A meniscal tear can be the source of the pain. If 2 cortisone injections didn't work at all, it probably is important to get a little more information about what the exact diagnosis is. So an MRI is always helpful to tell us about other problems inside the knee that can be treated. If you've already had an MRI study and it shows that you have some arthritis but no meniscal tear, then other treatment modalities can be helpful, things like bracing, physical therapy, and maybe moving on to these hyaluronic acid injections. So again, if the MRI has not been done yet, it would be helpful to get the MRI to understand if there's any other source of pain. And if there is a tear of the meniscus, in your case, you're under 65, the meniscal problem may be the source of pain that's not responding to cortisone. Cortisone doesn't always reduce the inflammation as we hope. It usually does, but doesn't always. So the suggestion is to perhaps get an MRI or try some other simple treatment modalities, including physical therapy and bracing.
Thank you. 3 more questions in the queue for right now. The next one, this one, 60 years old, they say. I had a knee arthroscopy 2 years ago. They told me I had a torn meniscus. I felt fine afterward, but the pain came back during the summer. I went back to see my surgeon last month and he started me on physical therapy. It's not working.
Well, most likely, if you had a meniscectomy a while ago, pain got better and then pain came back, it could be that the arthritis is a problem. Often, as I said before, meniscectomy and meniscal tearing is often the first stage of the onset of arthritis. Chances are you have developed arthritis, which is causing your symptoms at this time. Physical therapy makes sense. Injections make sense, either cortisone or this hyaluronic acid. Bracing makes sense. Weight loss makes sense. But it does make sense, though, to try physical therapy if the pain is returned. Whether or not you need to have a repeat arthroscopy really depends upon what your pictures look like, what the x-rays look at, and what the x-rays look like, and what the MRI study looks like.
Thank you very much. Another one just came in. I was seen by you and still have some inflammation since and pain from arthritis, but have gone back to work, which does work my knee pretty hard, and I am still worried about downtime if I do surgery.
Right. Well, so if you need to work and you can't take off time from work, it's really about exercise. Exercise is really the key to trying to stay fit, trying to keep your arthritis pain minimal, and trying to avoid surgery. Again, the occasional injection can be helpful. Bracing can be helpful. But, there are times when a condition warrants surgery, and surgery may be something that you have to consider.
Thank you. And then the last one that we have here, so if anyone else has any questions, please submit it. My orthopedic surgeon has told me that I have a, sorry, I said a pop-up, interrupt my question. Medial bone on bone arthritis, but my anterior side is fine, so I need a partial knee replacement. He does not perform them, so I am looking for a surgeon who does. Do you perform partial knee replacements?
I do.
Okay.
Yes.
And, so this was anonymous. If that individual wants to share their name in the chat, or what's the best way for folks to learn more?
One more time, I'm sorry.
Where should we point folks? I believe in the event page, we had how to get in touch with you.
Oh, yeah, just I'm at Orthopedics at Nazareth, so it's easy just to look us up online. You can look up Nazareth Orthopedics, or you can look up my name online and get our phone number and contact information.
And again, just to clarify, you do partial knee replacements.
Yes.
And then this was a follow-up from the individual who asked about the continued pain. I do brace, but they are working me hard, 51 years old.
I'm sorry, one more time. This
was following up on the other question about still having arthritis, but worried about taking time off from work. I do brace, but they are working me hard, and this individual is 51 years old. Yeah,
well, look, if surgery is not an option, which is understandable, the viscose supplement of injection, the hyaluronic acid may be the answer. If you haven't tried that, you should definitely try it. Again, sometimes the simple measures don't work, and you have to make some time perhaps in the future for surgery, but certainly try the hyaluronic acids if it hasn't worked for you or you haven't tried it yet. And also the chondroitin sulfate and glucosamine is very reasonable to try as well.
Great, thank you so much. And that is all the questions that we had.
All right, folks.
Yeah, I'll turn it back over to you, Dr. Steinfield, to wrap things up.
Well, thank you.
All right, well, folks, knee problems can be very difficult problems. That's why you need to see your orthopedic surgeon if things don't settle down quickly. Again, I work with 2 other surgeons at Nazareth Orthopedics. We're happy to see any people who have issues that are just not resolving on their own. So feel free to give us a call.
Thank you, Dr. Steinfield. Thank you, everyone, for attending.
Thank you.
Thank you all for attending. That concludes today's event.